Good morning, everyone. This is meeting number 19 of the Standing Committee on Public Accounts, Thursday, June 9th, 2016. And I remind everyone today that, again, we are televised, and so I would encourage you to turn your cell phones off or put it on a silent mode. Today we're conducting a hearing on Report 4, Drug Benefits, Veterans Affairs Canada, from the spring 2016 reports of the Auditor General of Canada. And appearing before us today, we have from the Office of the Auditor General of Canada, Mr. Michael Ferguson, the Auditor General of Canada, and Casey Thomas, Principal. And from the Department of Veteran Affairs, we welcome Walter Natinchuk, Deputy Minister, as well as Michelle Dorion, Assistant Deputy Minister, Service Delivery Branch, and Sid Corchenet, Director General, Health Professionals and Chief Medical Officer. We have an opening statement from our Auditor General and then a brief statement from Deputy Minister Natinchuk, and we welcome you again here today. Thank you for appearing.
Thank you. Mr. Chair, thank you for this opportunity to discuss our 2016 Spring Report on drug benefits for veterans. Joining me today is Casey Thomas, the Principal responsible for the audit. In our audit, we examined three areas. First, we examined the process that Veterans Affairs Canada used to add, remove, or limit access to drug benefits. Second, we looked at the Department's cost-effectiveness strategies. And finally, we examined how the Department monitored the utilization of drugs by veterans. Nous avons constaté que les décisions.
We found that decisions about which drugs to cover were poorly documented and not clearly based on evidence, such as veterans' needs and clinical research. We also found that timelines had not been established for the implementation of decisions. In one case, a decision to limit access to a narcotic was still not implemented 2 years after the decision had been made. We recommended that Veterans Affairs implement a decision-making framework that specifies the type of evidence required and how the evidence should be considered. The Department should use this framework in deciding which drugs to pay for and to what extent it would pay for them. We also recommended that the framework contain a requirement for the Department to update the drugs benefits list on a timely basis.
Some cost-effectiveness strategies, such as substituting generics for brand-name drugs and negotiating reduced dispensing fees with pharmacies. However, the Department did not assess whether these strategies achieved the expected results. The Department had also not implemented strategies related to expensive new drugs entering the market. We recommended that Veterans Affairs Canada periodically review its cost-effectiveness strategies to assess whether they were up to date and leading to reduced costs for drugs and pharmacy services. In addition, we recommended that the Department identify other potential cost-effectiveness strategies to pursue on its own or in collaboration with other federal departments. Nous avons constaté que le ministère surveillait.
We found that although the Department monitored some high-risk drugs, it had not adequately monitored drug use trends that were important to veterans' health and the management of its program. We recommended that Veterans Affairs Canada develop a well-defined approach to monitoring drug utilization. This approach should serve the needs of veterans and help the Department manage its drug benefits program.
For medical purposes, we found that the decision to cover marijuana for medical purposes was made at the senior management level rather than by the Department's Formulary Review Committee. We were unable to determine why this decision did not go through the committee's normal review process. We also found that Veterans Affairs Canada had identified the need to contain the rising cost of marijuana for medical purposes and had therefore limited the coverage to 10 grams per day. This amount, however, was double what was identified as appropriate in the Department's consultations with external health professionals and more than 3 times what Health Canada reported to be the amount most commonly utilized by individuals for medical purposes. Par ailleurs, ce n'est pas toujours le médecin de première.
The veteran's primary care physician was not always the physician who authorized the veteran to utilize marijuana for medical purposes. Although the department had concerns about such situations, it had not systematically monitored authorization trends to determine whether there were veterans using marijuana were also using drugs prescribed to treat conditions such as depression.
Marijuana prenait aussi.
We note that Veterans Affairs Canada agreed with our recommendations and committed to taking corrective action.
Remarks, we would be pleased to answer any questions the committee may have. Thank you.
Thank you very much, Mr. Ferguson. And we'll now turn to Minister Natinchuk.
Mr. Chair, members of the committee, Auditor General, ladies and gentlemen, I'm pleased to be here today on behalf of Veterans Affairs Canada. And joining me today, as was mentioned, Michelle Doiron, who is our Assistant Deputy Minister for our Service Delivery Branch, and retired Navy Captain Dr. Sid Courchaine, our Chief Medical Officer. I wish to thank the Auditor General and his staff for their ongoing contribution to assist the Department in achieving effectiveness, efficiency, and accountability as we support the well-being of our veterans and their families. As the Veterans Affairs Minister, the Honourable Kent Hare indicated, immediately following the tabling of the Auditor General's report, we accept all of the report's recommendations, and we are taking immediate action to ensure the health care benefits program is efficient, valued, and supports the needs of our veterans. To give you an idea of its size, in fiscal year 2014 to 15, Veterans Affairs Drug Benefits Program supported the cost for drugs for approximately 51,000 veterans in the order of $80 million. While the report found that most of the 2004 Auditor General recommendations related to the program were implemented, it did highlight areas for improvement with corresponding recommendations. La couverture médiatique se concentre.
Media coverage is concentrated on the cost of marijuana for the Government of Canada and maximum doses, which might detract attention from the fact that the report deals with all benefits.
Role in the payment of drug benefits could be misunderstood. So to clarify, it is Health Canada that is responsible for the regulation of medications for all Canadians, including our veterans. And Veterans Affairs Canada does not prescribe medication. Rather, it pays for medical treatments authorized by the veteran's physician or health professional. To review, the Auditor General's report found the following key 4 points. We do not have an adequate process in place to make evidence-based decisions related to our drug benefits list. We should review our cost-effectiveness and program efficiency strategies. Third, we need to contain the rising cost of marijuana for medical purposes. And finally, we have not analyzed the use of drugs which are not on our drug list but are accessible on a case-by-case basis to eligible veterans. The mise en œuvre des recommandations du vérificateur général nous aidera.
The implementation of the Auditor General's report will help us reach our objectives, which is to look after the health and welfare of our veterans in an effective manner. I will briefly talk about the department's activities in priority areas.
Systematic, evidence-based reviews support our decisions with regard to the drug benefit list. To determine which drugs should be included in our list, we look to the expertise of the Canadian Agency for Drugs and Technology for Health. Once Health Canada has approved a drug for use in Canada, this independent agency relies on an advisory body to review clinical, cost-effectiveness, and patient evidence and make recommendations about listing it on provincially based, publicly funded drug plans. A Veterans Affairs national pharmacist was hired last year and is working now with public health plan counterparts to identify best practices in formulary management. An enhanced drug benefit management team is now reviewing the program and developing a strengthened decision-making framework which will identify the types of evidence to be considered, when to consider them, and how they will be assessed to make formulary decisions. We are also improving timely access to the pharmaceutical support program for those men and women releasing from the Canadian Armed Forces. For example, last year in April, we implemented changes to ensure that retiring sailors, soldiers, airmen, and women continue to receive the same drug benefits from Veterans Affairs that they were receiving from the military based upon drug history and their eligibility for Veterans Affairs programming. Ancien Canada examine
Veterans Affairs Canada will examine and review the profitability of its formulary and will work with its partners at the federal level and the Pan-Canadian Pharmaceutical Alliance to improve the effectiveness and profitability by May 2017.
Canada and other federal drug plans and jurisdictions and consult with private industry to identify opportunities to implement cost-effective strategies for our program. Further, Veterans Affairs Canada will regularly assess and review its drug benefits list and claims data. This analysis will inform program changes to help reduce the administrative burden for veterans and lower the costs for delivering the program. With regard to marijuana for medical purposes, it would be worthwhile just to review the context of providing access for marijuana for medical purposes to our veterans. In 2001, Health Canada began providing controlled access to marijuana for medical purposes to Canadians. It controlled the adjudication of requests, product distribution, and costs, as well as setting consumption limits. Supporting regulations outlined which health conditions marijuana could be approved for and which specialists could prescribe marijuana for medical use. In the Canadian healthcare system, as I mentioned, the veteran's primary care physician is responsible to determine the appropriate health care treatments to meet his or her patient's needs. In 2007, based on the approval of a senior manager, the department approved the payment for marijuana for medical purposes on an exceptional basis for one client for compassionate reasons. Starting in 2008, Veterans Affairs allowed for coverage of costs related to marijuana for medical purposes for eligible veterans who were approved by Health Canada. In fiscal year 2008-2009, 5 clients were reimbursed with expenditures in the order of $19,000. By 2013, these numbers rose to 112 clients approved with expenditures in the order of $400,000. In 2014, Health Canada introduced regulatory changes which reduced its role to regulate and license private producers. Restrictions were removed on the quantity of marijuana which can be authorized by physicians, and the price was established by private producers licensed by Health Canada. Based on these changes, Veterans Affairs Canada instituted a practice to approve requests from eligible veterans of up to 10 grams per day if authorized by their physician or healthcare practitioner and if they were registered with a Health Canada licensed producer. Veterans Affairs Director General Health Professionals, who is also Dr. Courchaine, reviews any requests that exceed the 10 grams per day. While 6 such requests were approved previously and are now grandfathered, no amounts greater than 10 grams per day have been approved under the current guidelines. Since 2014, the number of veterans using marijuana for medical purposes and the associated expenditures have increased significantly. Earlier this year, the Minister of Veterans Affairs Canada, the Honourable Kent Hare, requested a departmental review to assess how we provide marijuana for medical purposes as a benefit to veterans. Cet examen ministériel prévoyant entre autres diverses consultations.
This departmental review, including various consultations, was launched in order to assess the current approach to providing marijuana for medical purposes to veterans as a medication. We will be able to take stock of the review in the coming months. Departmental representatives are consulting medical specialists, suppliers, and veterans who have been prescribed medical marijuana in order to learn more about the issue. These consultations are intended to help devise an effective monitoring approach to ensure veterans' well-being.
I wish to assure veterans and their families that there are existing alerts in our drug benefit system, as well as at the pharmacy and provincial healthcare system levels. Nevertheless, we absolutely agree that we need a clearer approach to monitoring drug utilization and detecting trends. We will ensure that our monitoring practices are systemically reviewed to ensure optimal efficiency while taking advantage of the best practices of other departments and jurisdictions. Strengthened processes will include regular and documented reporting to our Formulary Review Committee. Tout changement à la surveillance de l'utilisation des médicaments.
All changes to monitoring by Veterans Affairs Canada of medication use will respect the fact that veterans' health care is mainly the responsibility of their physicians or the accredited health professionals and the healthcare system.
I just want to assure you the work is underway now to address our shortcomings, and we'll have completely addressed each of the recommendations in the Auditor General's report by the spring of 2017. Again, I wish to thank the Auditor General and his staff for their work and assistance to support the well-being of our veterans, and I thank you for your attention. Merci.
Thank you very much, Deputy Minister, and we want to thank you for coming today, certainly, and for your testimony. We'll now move into the first round of questioning, and we will go to Ms. Shanahan, please, for 7 minutes.
Thank you very much, Chair, and thank you very much to the witnesses for appearing this morning. My question is for the Deputy Minister. I thank you for clarifying in your remarks somewhat more the role of Veterans Affairs in the administration of the drug benefits. Of course, our concern here is to assess the use of public funds, but also how those funds are used for the health and well-being of our citizens, particularly those who have served our country. And what I'm concerned about is how this problem came to blossom to this extent without before the Auditor General made his report. So I would like to understand much more the role of the new hire that you have, the pharmacist that has come in, and is this person enough to do the job that he or she has before them? The development of the decision-making framework, and in particular, why in your action plan the target dates are simply Q1, Q2, Q3. That I find is for a problem that has reached this urgency, why those target dates are frankly loosey-goosey.
Thanks very much, Mr. Chair. Madame, thanks very much for the question. I guess I would say that over time, in the effort to find efficiencies throughout the department and to structure through the department, there used to be a pharmaceutical team. Over time, that team was really decentralized throughout the department, and including a reduction overall in the number of folks with the expertise in pharmaceuticals in the department. And that's why last year we recreated this team, and we brought aboard the expertise to address and really create the leadership and the management and the structure so that we put together a decision-making framework and move forward with a very deliberate plan. Also recognizing that as we do move forward, we're working in partnership with our key partner, which is the Canadian Armed Forces and Department of National Defence, and Health Canada, to make sure that we are moving in lockstep with them forward. I think I'll just ask if Dr. Cushane could expand on parts of your question. Sit.
Thank you, sir. Thank you for your question. As it was mentioned, when I arrived at the department 18 months ago. There was no pharmacist, and I saw that as a gap to the good functioning of the Formulary Review Committee. We hired a very experienced pharmacist that came from the Canadian Forces, and we started right away to put in some procedures to tighten the decision-making that was identified by the Auditor General, but we had identified that even before the report came out. Ms. Westervelt sits on the Canadian Drug Review Committee that was mentioned in the opening remarks from the Canadian Agency on Drugs and Technology. She sits on several other committees that are all pan-provincial and federal. So our role mainly is to provide analysis and advice to the department, but also to the Formulary Review Committee. Everything that is presented now needs to be analyzed before it's presented for consideration, and we've established guiding principles. I would say that the decisions that were made at the Formulary Review Committee were not made willy-nilly, but the process could have been more rigorous, and one of the recommendations from the OAG was that there was lack of documentation. So now we have written analysis of items that are presented to the committee for consideration, and they are part now of the records of decisions of the committee, so that we can have that trail of how we came to consider this. And part of the guiding principles is also cost effectiveness. So there is an economic analysis done for every new item that's brought to committee.
Thank you very much, Doctor. And indeed, I don't see this as a problem of data collection, because the applications have to be made for the drugs and the payments have to be made, but indeed one of analysis. But I'll get back to the deadlines that you have in your action plan, and I think my colleagues will have further questions on that as well. So why do we not have tighter deadlines in achieving that decision-making framework? Since this is really it's at the analysis and decision-making point, and frankly, it's too far out, I would venture.
I think we gave those deadlines because although we do have a new national pharmacist and we are hiring staff, implementing new procedures take time. I don't think we're going to wait till that date to get things done. Things are underway. They'll be completed by. So we gave ourselves till next May, knowing that implementing change can take time to organize, especially when I have just the one pharmacist working with new staff that's been hired to support the drug formulary.
Okay, do I have any other time? Yeah, so what? Yes, please.
The only point I would add is we also want to make sure that our decisions are based on evidence in some of these cases, and to actually do the analysis. It does take some time to get the right, and now a procedure may not be that complex to write, but do we have the right evidence to make those decisions? And as Dr. Cochrane said, we're working diligently to get there. But we have to do that analysis and get the information from our partners, whether it is Medavie Blue Cross, who's our big supplier, or whether it is Health Canada or various jurisdictions.
Can I just I share your impatience. I want it solved yesterday. So again, the point that Dr. Cochrane mentioned in terms of no later than, really pushing on this team to get on with it again, getting the people into the positions, setting up what is the overall doctrine to make these decisions, but then to get it done like tomorrow.
Because this is blossoming.
Absolutely, ma'am.
Thank you very much, Ms. Shanahan. And we'll now move over to the opposition side and to Mr. Gaudin. Mr. Gaudin, 7 minutes.
7 minutes. Merci, Monsieur le Président. Not 5.
Thank you very much, Mr. Chairman. Ladies and gentlemen, thank you so much for being here this morning and for answering our questions. It's very important to us because as members of Parliament, it is our responsibility to try to improve the effectiveness, the efficacy of the practices of various departments. So that's what we're looking at this morning. I'm not going to talk about the recommendations or the answers you gave to the Auditor General because those are intentions. I have a more philosophical question, actually, to begin. Now, we know the scope of the problem facing our brave men and women in the armed forces who serve our country. They come back from missions involving military activities which may have led to PTSD. At Veterans Affairs Canada, Are you sure, are you certain that the solutions you're providing to our veterans now are the best ones possible? In other words, do you think it might be a good idea for you to review all of your processes, in fact, perhaps to start from scratch? The issue is growing, the problem is growing exponentially. The number of people taking medical marijuana is out of control. There are no controls. It seems that public officials are taking decisions, but there's no accountability before this committee. Can you give us a real picture, draw us a real picture of the situation on the ground, and tell us what exactly needs to be done? Thank you very much, Mr. Chairman, for the question. The priorities for our department is the welfare of our men and women. I agree with that. And our culture is one of caring and compassion and respect for our veterans and their families. That is absolutely clear, and we are partners with the armed forces, especially in view of the transitioning of our men and women from the Air Force and the Navy and the ground troops. We are there to help them transition. And it's a very difficult transition for many of them. Perhaps 1/4 of veterans have some kind of medical injury or issue, which is the reason why they have to leave the forces. But when they leave the armed forces, it's very important that they work with a doctor, a physician, for their care and treatment, and also for that of their families. So we work with the Canadian forces to make the transition as in the best way possible, and we try to work with them on the ground in where they live. So veterans, with the help of their physicians, or rather the physicians assess the needs of the veterans. The two have to work hand in hand to work out reasonable support for the veteran. Now, veterans who have asked for medicinal marijuana they may need marijuana to help manage their pain. Now, ultimately, it is the physician who decides whether medicinal marijuana or any other kind of treatment is good for the health of the veteran. Thank you, Mr. Chairman. As the Deputy Minister just said, the primary responsibility for care and treatment of a veteran lies with the physician. We are there to support, to provide support to make sure that the appropriate care and treatment is available. We try to support the physicians, but they are the primary caregivers for a veteran. So when a physician prescribes medication, well, these medications are paid for. Veterans Affairs Canada does not make diagnoses or prescriptions. That is the role of the medical community here in Canada at the provincial level and elsewhere too. Everything we do is based on the care, compassion, and respect for our veterans, whether they need help for mental care. There's PTSD, of course, but other mental issues. There's also physical pain. So these are the two great conditions which need to be addressed. We are modernizing our programs, be it along the lines suggested by the Auditor General, to make sure that care is provided in the appropriate manner and on time. Dr. Courchaine works a lot on the ground in communities with the physicians themselves to make sure that our veterans have access to doctors. And we all know that it's not always easy to find a doctor in Canada. I would just like to add, and I don't want to give any history lessons here, under the Canada Health Act, Canadian forces are excluded from the healthcare system. So when a member of the forces leaves the forces and returns to civilian life, responsibility for medical care lies with the provinces. But as you said, we know there's a problem when it comes to PTSD. The department has recognized that there are some of these members who need help. So we've established a network of clinics in 2001 to help alleviate specifically those mental health issues. So we have 10 clinics. We are partnering with these 17 forces clinics, so there are 17 in total. And we also have other clinical access points because some veterans live in isolated areas. So those clinics have established service points in remote or isolated areas. So in fact, we have a network of 27 points of service specifically to help veterans, forces members, and RCMP members who qualify for our benefits. This is something the department has established. And these clinics have 15 years of expertise in healthcare for veterans and forces members. And these clinics work outside of the public healthcare system. So I just wanted to remind members here that we have taken measures to address the needs amongst this vulnerable population.
Opposition again to Mr. Christofferson, please.
Great. Thanks very much, Chair, and thank you all for coming. Deputy, General, you have so many titles. Good to see you again, sir. I'd just say at the outset that I think it's fair to say that Canadians have been very, very unhappy with the way that veterans have been treated in Canada. And one of the things that the new government promised was that there would be a change. And I'm hoping that the answers we hear today indicate that there's going to be a change, that it's not good enough anymore to just say nice things and platitudes about veterans and then, but what seems like ignore them once they come home, especially if they're broken and need help. So I'm hoping that we begin to turn the corner and we hear that today from the answers that we're getting. Because quite frankly, it's been disgraceful, and that change needs to happen. And if I may, Chair, just also before I move to my detailed question, again, in looking at the action plan, which is a key part of what we do, and I've already suggested that maybe we need to look, in terms of our own self-improvement, I know that you're interested in keenly keeping us state-of-the-art, keep pushing the envelope, that we do as good a job as possible. So we've already talked about a little more analysis on that front of the action plans, maybe even asking the AG for comments around timeframes and such. May I also suggest to our analysts, when we're looking at that maybe we could offer up a bit of a template. It would be a lot easier if all the action plans were always laid out the same in terms of our efficiency and ability to grab what we need, rather than going through each one, having to figure out how have they laid it out, and then have to do the work. Small things, details, the public's not all that interested. It's inside baseball, but it is important to us, and I would hope that at some point we could pick up and refine our efforts in that area. The Auditor General will know, and Deputy, I think you would know from your past role, that one of the things this committee takes incredibly serious is when there are previous audits with recommendations, especially where the ministry has said, we agree, and then the Auditor General goes back in and finds out that it didn't get done. And let me say to you, Deputy, we've had occasions where there are multiple audits where we're still getting the department saying, oh, we agree, and they say all the nice flowery things that we want to hear, but then nothing happens. And this really launches us. It certainly launches me when I see that. And we have some elements of that here again today. If I can reference page 14 in the English document 4.59, pharmacy alerts. I'm quoting. In response to observations from our 2004 audit, Veterans Affairs Canada strengthened its alerts for the potential overuse of narcotics and benzodiazepines, I have no idea, which are sedatives, so that alerts are issued regardless of where the veteran filled the prescription. The department also partly addressed our recommendation to monitor instances in which pharmacists dispense drugs to veterans in spite of a pharmacy alert. These instances are monitored when they involve potential abuse or overuse of narcotics, and my benzo word, or when a veteran tries to obtain the same prescription from the same pharmacy within a 7-day period. And here's the kicker. However, all other instances in which a pharmacist dispenses a drug in spite of an alert, such as those related to a potential drug interaction, were not monitored. So I can ask the AG to further explain, but it sounds relatively self-explanatory. Can you please give us an answer as to why something that was uncovered in 04 needed to be fixed, but we only got a part fix, and there are some parts of that audit and the commitments this department made that have not been honored and kept? So, please, time for accountability. Why is that?
Sir, Mr. President, Mr. Chair, sir, thanks very much for the question. I'd like to say a couple things right up front and then ask Dr. Cushane to pile on. First is the department's culture. You talked about see a change in the department. I got to tell you, I speak to a lot of veterans. There are a lot of veterans there who unfortunately don't come to us soon enough, and we are changing our practices so that they come to us as soon as they're ready. It's part of dealing with the stigma of mental health, so that those veterans feel safe to come forward, that their families and their battle buddies support them to come forward, and that when they do come forward, that the department supports them. And that's why we put in place the idea of care, compassion, and respect, so that we are empowering our employees so that they have the opportunity and the authority to say yes when indeed a veteran needs support. So we're changing that culture. Just want to make sure that you realize that. And part of that culture is also including support to the families, because again, without the support of families, these veterans will not come forward. With regard to the 2004 audit, I just want to again say that we have actually made some progress in terms of putting the right trip flares and indicators that we are changing, but I'm going to ask Dr. Cushane to pile on at this point and just go into a bit more detail and better pronunciation of some of the drugs that you were mentioning.
Thank you. Appreciate that.
Thank you, Mr. President. I want to say up front, and I don't want this to sound as an excuse, but we are not a healthcare system. So we don't, we don't prescribe, we don't provide the care directly. So we manage a drug formulary. We make the drugs that our population needs available, accessible, at the best price for the government. There are alerts in the system. So I don't want to leave the impression that everything is reimbursed and there's no alerts. What was not happening in 2004 was that we were not asking for regular reports of Blue Cross Medivy, who administer the program for us, to give us those reports. But they do send us reports of people who are exceeding limits that we have decided to, and we do scrutinize those, and we send them back to their care providers. So we send letters to their care providers saying, did you know that we've been asked for 2 prescriptions? But things have changed in Canada in pharmacy. And pharmacists and pharmacies in every provinces are all connected now. There used to be a time when you could go doctor shopping for prescriptions, and you would go to 3 different pharmacies and nobody would know. Well, now they know. So now these alerts for drug interactions and for shopping around are done at the point of service. So we don't need to monitor that because it happens right there. And if a pharmacist sees that someone went around somewhere else at another Shoppers Drug Mart to ask for a prescription for benzodiazepines, then they will contact that pharmacist, contact the prescriber, and it stops right there. Same for drug interactions. Because we are not the care providers, we don't monitor that because the pharmacist will say right away, this drug is not good to take with this drug, you're taking this for your hypertension, and this drug should not be prescribed to you. They contact the prescriber immediately. So there's redundancies in the system now that we don't need to be monitoring that.
Thank you very much, Doctor. We'll now move to Mr. Arya, please, for 7 minutes.
Thank you, Mr. Chair. Doctor, you mentioned there's no more doctor shopping, but please refer to the Auditor General's report, para 4.63. Says that 29% of approximately 600 veterans obtained authorization from one physician. Again, same para, 53% of veterans obtained that prescription from 4 physicians. Is it not doctor shopping?
Thank you for your question. With respect to marijuana and authorizing, so I want to make the distinction that these are not prescriptions, they're authorization for access.
Okay, I'm sorry, authorizations.
Yep.
Yeah, didn't it raise red flags to see that one physician or 4 physicians almost authorizing more than 50% of the marijuana?
Absolutely. And this is an issue because many, I would say, most of the medical community did not want to be placed in the position.
No, I want to know, what did you do once this was identified?
Well, in one case, we did file a complaint with the College of Physicians and Surgeons of the individual that we thought were prescribing a lot. But the issue is that many doctors are not authorizing this. And so for people who want it, because the courts have said they have to have access, a reasonable access to marijuana, some doctors are more willing to provide the authorization forms than other doctors.
You talk about reasonable access, but the amount that is being spent, we are 3% of veterans are using 30% of the budget, $9,200 per person. Especially when the veterans, 36% of them are over 80 years of age. I don't know, it does not smell good for me. Are you compromising the prescriptions that are required by other veterans for other illness, say like kidney failure, because of the high cost that is being spent on marijuana?
Can I? No, to answer your question, sir, and Mr. Chair, and sir, no, not at all. Again, we provide support to the attending physician, so that the attending physician who is supporting the veteran, can make whatever prescriptions or authorizations that they require. But with regard to your concern, it's precisely for this reason that our Minister Kent Hare, has directed the department to conduct a review to look at all of the information that is out there right now in order to determine what is the most appropriate methodology, what is the best practice in terms of supporting the well-being of our veterans going forward.
I understand this, sir, but your own department data has got 46% of 600 veterans utilizing marijuana for a medical purpose were also utilizing antidepressant. Have you looked into that?
Again, sir, in every case, it is the attending physician who is working with the veteran.
So when you identified, what can be done by you then?
Again, having met with, the minister having met with medical experts, having met with the producers, having met with a group of veterans who are the beneficiaries of this program, and we have met with a summit of almost 100 veterans associations. coming together to understand all the information out there. Again, having been with a number of these veterans who will lay out a number of bottles of medication in front of them, and they have indicated that as a result of use of marijuana for medical use, they are no longer having to take some of these other medications which affected their appetite, which affected their sleep patterns, and so on. So, but in each case, I just want to reinforce that our role is to support the attending physician to ensure that that veteran has the support that they need.
Understand. Okay, several times you have indicated your role is just to pay. I think 2 or 3 times you mentioned in your reports or in your statement. Then, the federal government spends totally $500 million on the prescriptions. Why till now you have not worked with other departments to find a better strategy to cost effectiveness strategies there?
But, sir, we have continued to work with other departments in this regard. We've been working very closely, as I mentioned in my opening statement, with Health Canada. We connect as well with the Canadian Armed Forces. So the cooperation and the partnerships, not only with other federal departments, but other medical bodies, and perhaps Dr. Cashane could just expand on our partner.
Maybe the AG can explain to us. AG very clearly says that, the cost-effectiveness chart to assess whether they are up to date and leading to reduced costs. They recommend that cost-effective strategies should be adopted. Is it happening now, sir?
Let me interrupt just for a moment. Let's make sure that our questions come through the chair and that prevents the cutoff and everything else. We'll try to keep it a little more orderly.
Okay.
To the Auditor General, please.
Yes, sir.
Well, I think sort of the only thing that I can say is, in the audit report, we identified the issue around cost-effectiveness strategies, and that there were some things that the department should do to improve that. I can't really speak to sort of anything that the department has done since then, or what they've got in their action plan. But certainly, at the point in time that we completed the audit and reported on the audit, we identified some things that they were doing in cost-effectiveness strategies, and then some other places where they needed to improve.
And another question, you mentioned in your report that internal departmental briefing document indicated the risk of having more than 5 grams per day, and the Deputy Minister mentioned that the restrictions were removed. So there's a bit of you think that there's an internal document that states that usage of more than 5 grams per day is not recommended, whereas the Deputy Minister says that there are no more restrictions on that side?
As far as an answer. To our Auditor General, please.
Thank you. So, I guess in terms of that, I'm not sure if I can give you an answer quickly. Again, certainly what we identified was that the consultations that the department had done indicated that the normal utilization of marijuana for medical purposes was at certain levels. I don't think there's really a difference between what I've said and what the Deputy Minister said. That was certainly just sort of what the evidence. So what we were pointing out was the evidence and the information they collected at that point in time indicated that normal usage was more like 5 grams or less than 5 grams for medical purposes, but the limit was set at 10 grams. And I'm not really sure that I've heard that the Deputy Minister has contradicted that, or perhaps they have collected more information since then, but that certainly was what the information existed and the documentation existed at the time that we did the audit.
Thank you very much. Thank you for the question. We'll now move back to the opposition and to Mr. Poilievre, please.
On paragraph 4.46 of the report, it indicates that shortly after the regulations were implemented, the department once again identified the need to contain rising costs of marijuana for medical purposes by imposing a dollar limit that would be paid per gram. It found that the per gram cost had increased, and I wonder what is the major driver for increased cost per gram of marijuana?
Mr. Chair, thanks, sir, for the question. My understanding is it's part of the strain of the marijuana. In this regard, I'm going to turn over to my specialist, Dr. Courchaine, and Michelle Doiron.
There's a couple of factors, sir, that, thank you, Mr. Chair, for the question. There's a couple of factors that have influenced the cost per gram. Initially, Health Canada controlled the cost and they had capped the cost. When the regulations changed in 2014, there was no longer, that cap was no longer there per cost, and it's a free market. And then the cost per gram does vary per strain of marijuana based on percentage of THC or other products in the marijuana. And it goes anywhere from $7, $8 per gram up to $20 per gram, depending on the strain you buy. And the Auditor General in his report had highlighted that we had not capped a price per gram, and I'm paraphrasing here. And it was correct, and it's something that we've been asked to look at as part of the entire research by Minister Hare to look at which are the best strains, okay. And is there any cost effectiveness when it comes to the various brands.
Okay, and it says here that the cap on quantity was set at 10 grams per day. Is that a lot?
Thank you for the question. Yes.
Are there a lot of veterans who are using that much?
There are a fair amount of veterans using up to 10 grams, but they're not necessarily using them all. In some cases, they're making sure they have them and they use them when they need it, but yes.
But on average, then, they would be using 10 grams per day?
They could be, yes.
Has there been any consideration of how the health impacts that might have?
There has been a lot of discussion, sir, on the health impacts that this may have on the health of our veterans. And that is the basis, or one of the bases, notwithstanding cost effectiveness, notwithstanding other stuff as raised by the OAG, but one of the bases of the review that we are presently doing with health experts, with Health Canada, with our beneficiaries, to try to determine what would be the right amount, the optimal amount, and what benefits could become of that, and where does it become dangerous for the health of the veteran.
It seems to me that 10 grams of consumption in a single day, on average every day, could probably cause more health problems than it solves. I also note that the explosion in the budget for marijuana, here it shows that costs between 2013-14 and the first 9 months of 2015 rose by 25 times. That's twice the rate at which the number of veterans consuming marijuana increased. So we've increased the number of recipients by 13 times and the cost by 25 times. And that's only on a 2-year period. And then I see that the cost is expected to double again next year. So this is a phenomenal growth industry within Veterans Affairs. Just one last, my question is, are we prescribing medical marijuana for PTSD?
So just, sir, that marijuana is being not prescribed, but is being authorized for numerous medical issues.
Including PTSD?
Including mental health and PTSD. But the most prevalent is actually musculoskeletal issues, significantly over those veterans who have a mental health injury. And perhaps Dr. Courchaine could just mention a little bit more on this.
How many veterans are being authorized to have reimbursed marijuana for the purpose of operational stress injuries?
Well, I want to just clarify that we don't prescribe.
No, of
So,
course not.
so we don't prescribe for any issue.
Sorry, the
and that
question
would be their attending doctor would prescribe.
How many veterans are being prescribed or authorized reimbursement for medical marijuana for mental health issues?
I think it's in the order of 900.
And
Most, like the deputy said, most people report that it's mainly for musculoskeletal related pain.
those that are using medical marijuana for treatment of mental health issues, you say there's roughly 900. Has the department studied whether the use of marijuana helps or exacerbates those mental health problems?
Right. Well, I have to say that this is in the realm of clinical research, and we don't do clinical research. And so it's a very good question, and it's a question that is being looked at.
Thank you very much, Doctor. We'll now move to Mr. Harvey, please, for 5 minutes.
Very much. I'd like to thank everybody for being here today. I want to follow up on my colleagues' comments. And the reason I would like to do this is because the 10 grams a day, so I have a good friend that has he's a paraplegic, and he takes medical marijuana for that exact use. And in New Brunswick, until recently, the musculoskeletal rate was 1.5 to 2.5 grams per day. And it was increased in the last year to 3 grams per day, which is actually at the high end for the average. The actual identified, if you go to the Health Canada website and you look at the recommendations on there, it says the average for smoking and vaporizing, the median reported dosage was 1.5 to 2 grams per day, respectively. For edibles, the median dosage is 1.5 grams per day. For teas, was also 1.5 grams per day. So, what you're saying is that, and I mean, it's your department, and basically what it identifies is that Veterans Affairs has identified that the need of somebody that's a veteran is more than 4 times the amount of the average Canadian. And no, I'm not done yet, but when I'm done, you're more than welcome to speak. Okay? My reasoning behind this is that, and I also know that the average cost for medical marijuana is at the low end $6 on the average, and at the high end $10. So if you go with an average of $8, I do understand that there are strains that are upwards of $20, but that's on the very, very high end, and it's for very concentrated product. So if you have a veteran that's using 10 grams per day, which is more than 4 times the amount of the average user, at the high end of the dosage, to me, something in that just does not compute. And also, if you look at it, so if you figure it out on an average daily usage, the average daily in the medical marijuana study that was done of current users for medical usage across the country was identified at around 90 grams per month total usage. So according to 10 grams per day of usage, that's over 300 grams a month at an average cost of $10 a gram. That's $30,000 a year. I question whether all of that usage is being actually done by that veteran. Maybe that's not a conversation that anybody wants to have, but I'm lobbing out the question here because it's right there. And my other second question, I guess, on the end of that is, what is the specific budgeted amount for medical marijuana forecasted for 2016, 2017, and 2017, 2018? And I do believe that those numbers should be available somewhere, because in the Veterans Affairs Canada 2016-2017 report on plans and priorities, the budgetary numbers are there, so obviously there is a budgeted number.
Minister
Yeah, sir, just to say that your concerns are well-founded, and it's because of all of that you've just laid out is precisely why the minister has launched this review. You're exactly spot on with your points, but that's why the minister wanted to make sure that we we actually get the best evidence we can from across all of the realms, that is from the medical experts, from the producers, and going into the price points and the strains that you've mentioned, as well as the beneficiaries. And again, not obviously meeting with all the beneficiaries, but with a select group to understand the various perspectives as we try to figure out how to move beyond this guideline that was put in place in 2014, and how do you normalize this to ensure that there is not a unintended consequence of making the health worse for the veteran, and indeed supporting the physicians for the well-being of those veterans. So this is precisely why we're working on this. We've been working, and we've just had a summit of, as I mentioned before, of all the veteran associations here in Ottawa recently to educate the community in terms of the kinds of points that you've just mentioned. Can I just ask Michelle and Dr. Korshane if they could weigh in? I don't have the number on me with regard to 16 or 17, 18. Over to you.
Is pretty well up. I'll give you the extra time, but
okay. For the numbers, if it's okay with the chair, I'll provide the exact numbers. I have the numbers for our entire medication, but I don't have it with me for marijuana specific, so I can provide that to the committee after this if it's okay, because I have the general number but not specific. As the deputy said, this is exactly why we're following up on the policy. We did put into place 10 grams at that moment because once Health Canada changed, we were sort of caught, and we did cap and with the intention, and we had started looking at what is the optimal amount, what is the right amount, and that is the work we are doing in developing the policy, talking to the experts, talking to other jurisdictions, following up on the points you've raised. These are all, and we were aware of those, these are all stuff that we have followed up on. And even the producers, what is an average Canadian take versus a veteran? And they have different categories. I won't get into all of it, but who takes what? Some are at that level, some are a little higher, some are actually lower, it depends on. And to come up to a reasonable policy that will meet the needs of our veterans, ensuring their health, but also meet the needs, make sure that we're not causing a downstream effect with the marijuana.
Thank you. I don't know, Dr. Korshane, did you have comment on that?
With respect to the amount, we can't assume that they're smoking the entire 10 gram every day. And when we talk to the veterans, some put it in their smoothies, some make brownies with it, some extract oil, which requires higher quantities. So they don't, we can't assume that all of our clients are at the high end of the 10 gram.
Mr. Harvey's going to burst if I don't let him back in here.
The only reason I want to make it is because it's right on the Health Canada website.
Yeah, I've got it right here. That's what they report.
Right, what they report
They're not recommending, they're reporting.
No, but what they're reporting is what their findings have been, based on the evidence not only from here, but from a study that was based out of the Netherlands, that actually when marijuana is consumed in alternate forms besides inhalation, the actual amount that's consumed on a daily basis goes down.
Yeah.
So to say that that is a plausible reason as to why consumption levels could be so high is categorically false.
Thank you, Mr. Harvey. Maybe we'll have a chance to come back to you on this. We'll go to Monsieur Gaudin.
Merci, Monsieur le Président.
Very much, Mr. Chairman. I appreciate my colleague asking that question. It's very relevant. I have a question for, well, I don't want to demolish what is being done right now, but I think we're in the process of creating a monster. Before marijuana became legal, what did we do? Were our military members, did they receive less treatment? Were they in a worse situation? What has caused marijuana to become the silver bullet? It's being prescribed for everything. The budget's gone up by 25%, and it's gone up 25 times in the last 2.5 years, so from 2013, 2014. So what were we doing before? That's my question for now. I have other questions, but what were we doing before to treat PTSD? Alcohol? Was alcohol being prescribed? Well, marijuana for medical needs is not only for PTSD or mental issues. Our information indicates that with muscular skeleton injuries, marijuana is effective, even more so that for mental injuries. And with modern medicine, we found that physicians are giving authorization for certain pharmaceutical products, but marijuana seems very effective with our veterans, but it's a very complex issue.
Le point que je ferais, c'est qu'avant 2014,
The point I'd make is that before 2014, our veterans had to go to Health Canada with their information. They were reimbursed for their costs, but it was a very lengthy process. It doesn't mean veterans did not use it, but we did not reimburse those costs for the ministers. The deputy minister said since 2014, when the rules changed, physicians were able to authorize medicinal marijuana, and then we paid. But before that, the individual had to go to Health Canada for an authorization, and Health Canada had very tough standards. I don't know if the Supreme Court, but one court caused the regulations to be changed. These were changed, and that affected us. And that's why the situation was different then, and why there was an increase by 25 times. I'm not saying that before 2014 our veterans did not use marijuana, but the process to obtain it was much tighter, and it wasn't controlled by physicians. But now authorizations come from the physicians. So what I understand is that we've implemented measures to make it easier for veterans to access marijuana. Now, we are lawmakers, and we are witnessing the explosion of a budget. Where's this going to end? There are only 9 months, rather, we still have 9 months to go in this year, and yet the budget has increased 25 times. We've got to control costs. A little earlier, we were talking about 10 grams a day, but we've heard that perhaps veterans are using that every day, perhaps not. We have to be more rigorous. As a legislator, I'm very uncomfortable about the fact that the budget might explode and that there are no controls. So what are you going to do to rein those costs in? I'm not saying that there should not be access to marijuana. I'm not saying that it is not an effective medication, but I'm saying it might be too accessible. And it seems that everything is great. Any veteran can get marijuana and will be, can get high anytime they want. No, we can't have that attitude. We have to be more rigorous. And how would you go about that? Well, Mr. Chairman, as I said previously, the authorities to prescribe marijuana lie with the attending physician. The physician is responsible for the mental and physical health of the veteran, and it's important to insist on that point. Now, you've raised the concern, and they're legitimate, and that's why at this moment we are reviewing all of our policies and recommendations have been made to the ministers. So we are going to consult with the experts across the country and also with veterans who are using marijuana. We share your concerns, and as the Deputy Minister said, this is why we are currently working with experts. We are working with the medical community to develop a policy which we will present to Minister Hare. We want to make sure that our procedures with regard to marijuana, we want them to be more clear and precise. with regard to quantities, costs, etc. I don't want to get into the details now, but marijuana is different from other types of medication. Other types of medication, before they are prescribed, they were analyzed, approved by Health Canada. You've got a sore throat? Well, here, take some penicillin, take it 3 times a day. Well, I'm not a doctor, but when it comes to marijuana, we don't have that expertise yet, be it here in Canada. There are trends, and it seems that medicinal marijuana does help.
I just think for those who may be watching this or others, I think the concern, we've heard part of the concern, in fact, in Deputy Minister's opening statement where he went up to 2013, where we saw an increase here. But in 2013, $408,810 were budgeted or were used, and 112 recipients. In 2014, $5,160, $747, 628 recipients, and in 2015, $12 million, 156,000 and some, 1,320 recipients, with a forecast of doubling again next year. So that would be $25 million. So when you go from 400,000 to 25 million over 3 years, if we don't ask questions on that, people will be shaking their heads, I'm sure. We'll go to Ms. Where did Ms. Zahid go? Ms. Mendez is back. I had Ms. Zahid on the list. Thank you very much, Ms. Mendez.
Thank you, Mr. Chair, and thank you all for being here and for the comments. I'd like to start by saying something that I'm perhaps going to seem the odd one out here, but I'd like to take away the value judgments and the moral judgments that I'm hearing a lot about the veterans' use of marijuana. Okay, I do not want to have our veterans seen as, you know, using this as just a joyride that some people are assuming they are. So that was my first question. My second one, and again, all about the costs and how we're using the budget that is being utilized for the authorization of the use of marijuana, not the prescription. Do you have any comparisons of the, okay, you know how much you've spent on the marijuana. How much did it lower in your other medications? Because I mean, the Deputy Minister actually made a point of telling us that some of the veterans said that they made the example of showing a full pack of medications and what they stopped using once they started marijuana.
Mr. Chair, Madam, thank you for the question in both pieces. And again, many of the first part of your question, many of our veterans find marijuana for medical use to be beneficiary to them. And again, it is very compelling, and the challenge is it's very anecdotal. And as Dr. Courchain indicated, we don't have a medical research branch in Veterans Affairs, but with National Defence, with Health Canada, we partner in the creation of the Canadian Institute for Military and Veteran Health Research, which is basically a system of systems of all of the medical schools across Canada with research branches in all of our universities who do research on both military and veteran health issues, and also link to our allies in the US, UK, Australia, Netherlands, so that we're aware of the best practices across the board. And that's what Dr. Courchain is, our linkage into that network of researchers, and this is clearly a significant body of research. The challenge is the evidence, as has been mentioned, isn't there yet. And yet anecdotally it is so compelling when you meet with our veterans, and they will lay out all the bottles of various medications that they no longer take because they are now being able to take marijuana for medical use, and they are able to sleep, they're able to eat, and they're able to undergo treatment at our operational stress injury clinics. They're able to undertake vocational rehab and education, whereas under all of these other various drugs that I can't pronounce, that they were in a fog and they could not function. And so we have that anecdotal information which again was an education to me as it was to many in the department, and again hearing from the medical experts from across the field. I think that's really important. The second is that, and there was, I think, a media story about this recently, about this indication that from our budgeting that the cost for opioids and other pharmaceuticals had gone down, and that, as has been mentioned, marijuana for medical use has gone up significantly. While we recognize that those two numbers are correct, we do not have sufficient evidence to make a causal relationship.
Would it be possible to ask you to have it eventually?
We are certainly looking at all of this information.
I think
would
it
just
would be
ask my
important,
colleagues.
actually. It's part of the whole...
Yeah, I would ask my colleagues to chime in. Michelle?
As the deputy mentioned, we are seeing a decrease. Now, whether it's causal or not, it's very difficult at this point to, because we've just started to see that decrease, correct? So we are following.
But it's only since 2014 that it has been
well, more in the
last...
actually, it was more in the last, I'll say last year that we've seen on the side of opioids and tranquilizers. But we always have to be careful to jump to conclusions when we see a decrease somewhere or not. Anecdotally, as the Deputy Minister said, we've been told. And the veterans are actually showing us, these are the medications I used to take, and now I smoke whatever number of times a day, and here's what I can or cannot do. But we have to be careful because sometimes they still take, but it's a different dosage of medication. When you had certain, and I'm not a doctor, but a certain force to the medication, now their doctor are prescribing lower amounts of the drug to be able to better handle whatever illness they may have, whether it's musculoskeletal or mental health issues or others, right? Because marijuana can be used for various stuff. So, but we are tracking, we're starting to look at it to try to determine, is there a causal effect? And will that causal effect mean going forward our forecasts have to change? At this point, I would not even want to dare to give an answer on that because I think it's way too early in the analysis. But we have seen a decrease in the opioids and the tranquilizers.
Thank you very much. I think I'm done, no?
Seconds.
You'll
give it to Mr.
We've taken, yes, I will give them to Mr. Christopherson.
Thank you very much, Ms.
Thank
Mendez. We'll now move back to Mr. Christopherson, please.
Very good. Thank you, Chair. Doctor, benzodiazepine. Got it? Am I close? All right. We're getting there, General. We're getting there. All joking aside, though, I wanted to compliment Madame Mendez and her comments because I was having the same feeling that we're starting to walk down a moralistic road in terms of evaluation rather than a medical one. And damn it, if that's what soldiers need when they come back after defending this country and they're in those kind of war zones, nobody was being overly moralistic when we sent them off over there. Nobody was being overly moralistic with their families when there's the potential that they may not even come home alive. Damn it, if this helps them, then it needs to be there. Nobody's talking like this about the cost of cancer drugs. We have to talk about them in terms of containing the cost, but not about whether or not morally we think that this is an appropriate medicine to be giving to a fellow Canadian citizen who put on that uniform and went off into that war zone and got broken and came back and believed that the commitment this country made to them would be honored. So I'm so glad you went down that road, and I appreciate it, and I support 100% what you said. Having said that, though, we do have an obligation in terms of the approach of drugs, and I want to just bring us back to the Auditor General's report, page 10, paragraph 4.42, and I quote, "We found, however, that over the following 2 years, department officials did not pursue product listing agreements with pharmaceutical companies. We also found that not using them has limited what it can include on its drug benefits list because of the costs of some drugs, because the cost of some drugs are too high." End quote. And when I look at the action plan, on page 2, I see under cost effectiveness strategies, continue working with other federal drug partners and the Pan-Canadian Pharmaceutical Alliance to explore opportunities to enter into product listing agreements. What's the problem? I would have thought the recommendation would be, yeah, we've done it, or it's on the brink of being done, or we're negotiating the actual final detail. Why is it so difficult to get into this agreement?
Mr. Chair, sir, thanks very much for the question. Again, from my previous life, if I can lead, I'll lead and I'll take the hill. In some cases, I don't always have the lead, and we have to work with other government departments. And we are working very closely with Health Canada in this regard that has the lead for the PLAs. And we are, again, trying to move very quickly with them so we can sign up with them and other government departments. And again, National Defence, Indigenous Affairs, and other departments have significant pharmaceutical programs as well that as a collective we can work with various companies in order to land a preferred pricing schedule in terms of some of these pharmaceuticals. And I'll ask Dr. Courchaine or Michelle to pile on.
Michelle.
You know what? Before you go on to that, my next question is going to be, why wasn't it a bigger priority sooner? I mean, this is not rocket science. We didn't need, high-priced auditors to come in and tell us that, gee, when you join these bulk buying agreement deals, you save money. I mean, duh. Yeah. Why is it taking so long? And why with such a weak need response? And I hear you saying the complication, Deputy, I accept that to a certain degree. But I'm not going to accept that as a reason why we're not doing it, because it's complicated and it involves other ministries. I get that. It makes the challenge greater, but that doesn't mean you just walk away from it. So help me understand why something so plainly obvious isn't already done.
Christopherson?
Sir, we will move out with all dispatch in order to implement this as soon as possible.
Thank you. I see the light is on for Dr. Courchaine. No? All right, good. We'll now go to Mr. Lefebvre and then to Mr. Poilievre.
Mr. Chair, just before I start, my colleague, Mr. Harvey, wants to make a statement or ask a question.
Mr. Harvey.
Thank you, Mr. Chair. And I have to leave, and I don't have a question. I just wanted to, since we're on the moral high ground issue here, just wanted to state something for the record, which is that my comments towards Veterans Affairs today and my questions weren't centered around the moral implications or any regard in veterans and my appreciation for those veterans, period. My comments are centered around my belief that Veterans Affairs has made a misdiagnosis of what the maximum level should be compared to the rest of the comparative data from across the country, and that is here today reflecting their belief that is correct data, and I believe that that's wrong. It's not a judgment on veterans, period.
Thank you, Mr. Harvey. And now to Mr. Lefebvre.
Thank you, Mr. Chair. Just want to ask a few questions on this Formulary Review Committee and who sits on it, because from the Auditor General's report, they're responsible for reviewing, maintaining, revising its drug benefits program, and as well as making recommendations and providing guidance to its seniors management. So who sits on it, on this committee? And now now that we're talking about evidence-based decisions, how does that change from what it was before to now? Because I know that you guys are reviewing it. So what was occurring on this committee before, and what has changed since now that you guys are doing your review?
Chair and sir, thanks very much for the question. I'm just going to start and then I'll ask Dr. Courchaine to weigh in. So the Formulary Review Committee is comprised of health professionals from our own department. That includes Dr. Courchaine and our National Pharmaceutical Advisor, as well as the pharmacists and the medical consultants from Medavie Blue Cross. In addition, that we have our service delivery specialists from Michelle Doiron's team, and we also have members of the Canadian Armed Forces on that team.
And that has always been the case? Yeah. Because Madame Courchaine made a statement in her at the beginning, says there were no pharmacists involved. Can you maybe expand on that? You made a statement, or maybe
when I arrived, there wasn't a pharmacist in the position.
Okay, so there was
from the department, but there were pharmacists on the Formulary Review Committee.
There were.
Yes, there were from Blue Cross Medavie.
Okay, so now again, just the next part of my question. Now that we are looking at evidence-based, how does that differ from before?
So again, now what we've done is we've recreated leadership in pharmaceutical advice in the department that had been lacking for a few years. So while we had pharmacists, they weren't Veterans Affairs pharmacists. Yes. It was from Blue Cross Medivie and others. Now we actually have recreated the critical mass and the core of decision-making inside the department. So we actually now have some structure, develop the strategy, develop the plan, and capture it in a very rigorous way so we know how the decisions were made, when they were made, and again, going back to the Auditor General's point, when we're actually going to achieve these things to get it done in a timely fashion. Sid?
So I guess I'm asking, why wasn't that done before and why is it done now? Do you have more resources now? Is this more best practices? You guys have self-evaluated and...
I can't really speculate on before I got there. And so I can just say when I got there, what I observed, and the way forward as the deputy has indicated.
If I may, Mr. Chair, I guess we were relying on our partners to make some of these decisions. And when Dr. Costrain arrived, we started looking at how are we documenting those discussions or those decisions. And the OAG did raise that in their audit, that we had not properly documented some of the decisions. And I think there was a reliance on Medivie Blue Cross to provide us, and they're a great partner. They are incredible. But so we decided that that the department had to take that responsibility on by the department, not by a third party, to ensure that the decisions were correct. Yep. But more importantly, from a government perspective, that we were documenting those decisions and following through with them.
And has mental health now become more of a priority within the review committee? Or is it just one of the other?
Sir, mental health, exactly along physical health, is always a priority. So it is center of mind constantly.
Good, thank you, Mr. Chair.
Thank you, Mr. Lefebvre. We'll now move back to Mr. Polyev, please, for 5 minutes.
It says in section, in paragraph 4.63, that 29% of the approximately 600 veterans authorized to utilize marijuana for medical purposes had obtained this authorization from one physician. Why is it that such an enormous number of veterans went through a single physician to obtain the authorization for marijuana use?
Sir, we can only speculate that our veterans are networked with each other. And again, they have had a common experience in operations, be that in Afghanistan, in Bosnia, Rwanda, Somalia, or operations prior to that. So they are networked, and they are dispersed from coast to coast to coast in the country, some in remote areas, some in larger areas. And when a soldier, sailor, airman, or woman hears that something is working for somebody else, but they will share that.
They're dispersed. It seems that would be a reason why they wouldn't be going to the same doctor.
But the other challenge that we have is there are physicians in the country who will not prescribe, and therefore
that's the point.
And therefore, that's one of the challenges. At the same time,
sorry, I don't mean to interrupt. Just that we're very tight on time, and just building on that, on your point, we found that 53% of approximately 1,400 authorized to use marijuana for medical purposes had obtained this operation from 4 physicians. And so you've said that a lot of physicians won't prescribe this. There's probably a reason why they won't prescribe, and I don't think it's because they're engaging in moralism, as some has suggested earlier. It's probably because that they have some question as to whether or not marijuana is the right treatment for the person who is sitting before them in the doctor's office. My worry here is that I've been to the operational stress injury clinic here in Ottawa, and they specifically say that in order to treat post-traumatic stress, you have to confront the underlying trauma that caused it. So, and this is very difficult and painful because people who come back from theater are experiencing extraordinarily painful memories, and they actually have to relive them in order to treat the stress symptoms that they are enduring. My worry is that marijuana is being used as a numbing treatment rather than as a real treatment for the underlying cause of post-traumatic stress, and that could be why so few doctors are prepared to actually prescribe it. The other worry I have is that the quantities in question, a maximum of 10 grams a day, that's according to the Government of Canada, 1 gram produces 2 joints. So 10 grams, that's 20 joints a day. That's like smoking a pack of cigarettes and every single cigarette being filled 100% with marijuana. So I have a hard time believing that this is medically sound. Based on Health Canada, Mr. Harvey found earlier today Health Canada's observation of marijuana consumption. The amounts here are 4, 5, 6 times higher than those amounts highlighted on the Health Canada website. Do you share any of these concerns about the possible excessive prescription of this solution for our veterans?
Sir, you're absolutely correct in your concerns, and we share all those concerns. And this is the reason why our minister has asked for this review, to try to get as much of the real information across the board from the best researchers in the country, and to hear the perspectives from our veterans as well. The challenge for many of our physicians across the country is that there is a lack of evidence behind the use of marijuana for medical use. It is still very much an experimental treatment, but for some veterans, they find it to be very beneficial so that they can undergo treatment, vocational rehabilitation, and so on. But for all of the concerns, that's precisely why we're doing this review, in order to provide recommendations back to our minister on how to move forward on this important issue.
And will that review look into the psychological benefits versus the psychological drawbacks of abundant marijuana use among veterans suffering with post-traumatic stress?
If I could ask Dr. Courchaine, Mr. Chair, to just briefly mention she met with some of Canada's top medical experts on this topic.
Yes, and the policy review is including an extensive literature review, and we're working with Health Canada. They've been very gracious in sharing this literature review that they're doing on that. So certainly that will be factored in our policy review. Thank you.
Thank you very much, Doctor, and thank you, Mr. Polyev. We'll now move to Ms. Zahid, please.
Chair, further to the discussion on the marijuana, we appreciate the department's progressive initiative on giving access to veterans who require marijuana for medical purposes for their health issues. There are several concerns expressed in this report regarding the amount prescribed and, as discussed previously, for the eligible veterans. Intervention during excessive drug usage, high-risk use patrons, and containing costs associated with it. It seems that this program was begun without a sound policy developed initially. So on how it should be implemented and administered, can you discuss department's policy with regards to medical marijuana, why it was created, why you felt that there is a need that it should be created?
Yeah. Mr. Chair, Madam, thanks very much for the question. Again, in 2001, Health Canada indicated that marijuana for medical use should be accessible to all Canadians, and in that regard, veterans are part of that, obviously a part of our nation. In 2007, a senior official in the department did approve, on an exceptional basis, marijuana for medical use for one individual for compassionate reasons, and it was an end-of-life situation. In 2008, again, because the Health Canada then, we then expanded it in 2008, and the department approved for a small number. But at the time, it was covered by the regulations of Health Canada that prescribed which physicians could authorize, under what circumstances, and to what limit. And then all of that changed in 2014. And so at that point in time, the department had to expand its guidelines. And I'm just going to ask Michelle Doiron to expand a little bit on that.
And the deputy is correct. And at that point, as the chair had mentioned, we had limited individuals coming to us, and after the changes to the guidelines or liberalization of the guidelines, where a treating physician could authorize the use of marijuana, we started getting a lot of demands. And our policy was not, because it's not a drug, as are other drugs. But we had already agreed to pay since 2007, or 2008, 2007 was one case, we were already paying. So then we had to react to this growing, and we looked at what were the beneficiaries asking for, what had been approved in that short period, because we put in this, I won't call it a policy because it's not a policy, but this cap, in June of 2014, which was pretty quick after to sort of say, okay, wait a minute, we're not sure what's happening here, but we have to sort of understand what's going on. And we capped it at 10 because 80% of our veterans were asking for that or less. And
you prescribed an amount of 10 grams per day. It was doubling the amount as identified by the Veterans Affairs Canada consultation with the external health professionals, and it was about 3 times more what the Health Canada recommends. So how was this amount of 10 grams determined?
We went to what was being requested and what we had been paying since the opening of the act, and then it was based on us going out and trying to figure what is the evidence. And to be honest, for medical purposes, the evidence is it's starting now, but at that point in 2014 was, I won't say non-existent, but sketchy at best.
No, but if between, Chair, with your permission, between those 2 years, 2014 to 2016, if the evidence started coming in, so why you did not take any steps to go back and do further research and prescribe the amount based on the evidence available?
Again, I want to avoid the use prescribe. It's authority, and it's the authority of a physician, for his or her patient to have access to an amount of marijuana. So the relationship between that physician and the patient. And so in 2014, the department, trying to capture most of the authorities based upon the physician with the patient, set that limit at 10 grams. Clearly, that is higher than what Health Canada has said. That's precisely why we're doing this review now, in order to provide advice to the minister on how to move forward with this very important issue.
Thank you, Ms. Zahid. We'll now move to Mr. Christofferson, I believe. Okay, Mr. Gaudin.
Oui. Merci, Monsieur le Président.
Thank you very much, Mr. Chairman. I would like to clarify my position as a Member of Parliament. My objective is to help you find solutions so that our veterans are well cared for. I don't want anything I've said to be interpreted as minimizing the problems. Cost is one factor, but the most important thing is for veterans to receive the best care. So what I would like to know today is this. Has everything been done to find the best solution? And if marijuana is the best solution, and as Ms. Mendez said earlier, is this because with the accessibility of marijuana, other drug use has gone down? My question is for the Auditor General. In light of your audit, can you reassure this committee and tell us that veterans are in control of the situation, or rather the Veterans Affairs Department is in control and bring about the best measures to contain costs and provide the best treatment? Well, as we mentioned in the audit, there are different issues at stake when it comes to this program. Clearly, there are problems which need to be addressed if we are to have a program that works on a cost-efficient basis. This is one of the many aspects of the program we looked at. So the department will have to bring about improvements in order to have an effective program. Now I have a question for the department. Can you tell us today, on June 9th, 2016, that you are going to implement, since you agreed with the Auditor General's recommendations, and you've shown good intentions, but do you have the tools you need? Do you have the resources you need and the data you need? And again, I don't want to be putting words into your mouth. Do you have all of these things to better manage public funds, to maximize the program, and to ensure that our veterans have a good quality of life within the means at our disposal and given the medications available on the market? Thank you for the question, Mr. Chairman. We share your concerns and your priorities, which are the health and welfare of our veterans. This is an absolute priority for us. And to answer your question, I have full confidence in our plans. I have full confidence in our officials and in the leadership of our department. I believe they will address the weaknesses which we have found through the report. And again, I greatly appreciate the help of the Auditor General. So now, with our leadership, with our physicians, and with our pharmacists, and with our plan in hand, we are going to address these issues. Thank you very much, Mr. Chairman. That's all I have. I know I've got time left, but I'll share it with my colleague if he has some questions of his own.
But I just want to get something here. We'll be, as you know, issuing a report on the study that we're doing here. And just so I understand this correct, although we've seen this explosion in the use and in the quantity of medical marijuana, we have anecdotal evidence that other pain relief, other medication has diminished. That's all anecdotal. There is no evidence as far as data that says, yes, the number of medications has been diminished, the number using them is diminished, other medications, and the cost has diminished. There's no evidence for that. It's more anecdotal. You know, you have the veteran sitting there and says, all this medicine I don't have to take anymore. Is that correct?
Mr. Chair, we actually do have evidence, as you indicated, that the costs, the use and cost of marijuana for medical purposes has increased exponentially. We also have evidence that the use of opioids and other antidepressants have gone down.
Proportionally?
What we are lacking is the causal relationship. We are lacking that one went up and the other went down.
But given the excessive jump, you know, in the use of medical marijuana, I mean, you know, doubling over the next year to 25 million, how much of a decrease? Like, I mean, is it just minuscule, or is it, you know, would it may not be exactly proportional, but is it close, or what type of evidence do you have there?
Thank you for the question, Mr. President. It is not one for one. And that's a causal effect. We've seen a very high increase on the marijuana, usage and costs, but the relationship is not one for one. We have seen a decrease. We're trying to analyze what is that decrease and for why, but it is not directly proportional. Far from it, actually. So that's what we're trying to analyze.
Okay, so far from
Yes.
proportionality. Right.
Yes. Now, we've only started to see that decrease. So that's why we are studying to see what will this materialize, what would it look like, and we are tracking that and working with our partners at Medavie Blue Cross to sort of tracking the opioids, tranquilizers, antidepressants, and some of the pain medications to see what is the, but at present, today, it is not directly proportional.
Thank you very much. Back to Ms. Mendez, please.
Merci beaucoup, Monsieur le Président.
Thank you, Mr. Chair. I would like to thank you for having clarified these facts. I think it's very important to continue this study,
which validates the relationship between authorization for the use of marijuana to treat certain illnesses and also chronic pain. I think marijuana is very effective for that, and I think many veterans take medicinal marijuana for chronic pain. But I'd like to come back to the Auditor General's report, which not only deals with marijuana as a medical treatment, it also deals with all medications veterans need. The study you're conducting now, the research you're conducting now on the program itself, are you going to study a causal relationship between medicinal marijuana, other medications, and the budgets that go with both? Well, that's our intent. That's our plan. And thank you for the question. I cannot anticipate the results of our studies. So as we move forward in our study, as we gather evidence on marijuana and on the increased costs and a reduction in the use of other medications, well, all of this is going to lead to a policy on marijuana. What we are hearing from our veterans is that I don't need to use medication A, B, or C anymore, or my doctor has prescribed lesser doses of those old medications. I used to take a certain number of grams per day. Now I take fewer because I'm taking medical marijuana as well. Now, clearly, you're talking about pain relief, yes, but also antidepressants and opioids. That's what we're looking at. And it's still very early in the game, if you will, before we develop our policy on marijuana. That is something we will do, but as research comes out in the public domain, as our own research with our own partners progresses, well, we intend to have a fairly flexible policy because we need to meet the needs of our veterans. And I'm glad the committee pointed this out because our primary mandate is the welfare of our veterans. So as we move forward in our studies, as more people take marijuana to treat certain conditions, well, we expect to regularly review our results to make sure that our policy is always up to date and meets the needs, not only that it is effective and efficient, but it keeps on meeting the health needs of our veterans. In the short and medium term, of course, we want to make sure that you and your department will be followed by our committee. We are going to come back to this issue over the years. Of course, we will be doing this in the interest of our veterans. And that's why it's difficult to look at your budget projections. And you might think it's strange that I'm saying this, but I'm looking at your budget projections. There will be some increase from year to year, but nothing significant. My question is, how can you anticipate what the medical needs will be of veterans? I imagine that you might have historical data that you're using as a basis for your projections. But isn't that really difficult to anticipate what the need will be? Well, I'll say a few words and then Dr. Courchain will complete my answer. Of course, it's hard to anticipate what costs will be, yet it's important to understand that for us, if there's whether it's one veteran or 1,000 veterans who come to see us, we want to help. Well, that's exactly my question. You don't know. And in principle, you cannot refuse to help a veteran. That's right. And our budgets are based on forecasts, annual forecasts, which are based on historical data. And they're also based on constant numbers of our military members. However, if there are more conflicts in the world, we send out more people, well, we can expect an increase in the need for medical treatment. But our forecasts are based on historical data and consultations with our military community. So we project the number of members who will retire. We project the number of new people who enter the forces. All that is put into our data. And again, we regularly review our numbers with Treasury Board. We make the necessary adjustments on an ongoing basis.
Mendez, and thank you to our guests for appearing before our committee today. I think you've attracted a lot of interesting questions, but I think above all else, we want accountability and transparency, and we want to know that that one department, say Veterans Affairs, isn't working against the best recommendations of Health Canada, and certainly when we have an Auditor General's report, our job is to go through this. Let me just say also that because of the number of questions that we've fielded today, if you leave here and all of a sudden think that, this was missed or something else, or maybe we didn't have enough time to complete an answer that you would have liked to give a little more information in regards to, please submit that answer then to our clerk, and she will see that each one is copied some of that. So we're going to suspend. I'm going to ask the committee to stick around for a moment. We've just got one small item on committee business. It wasn't on the agenda, but I think we have agreement to go to it just very briefly. So we will suspend and come back here in about 2 minutes because our time is almost running out. So we thank the individuals who appeared today. Thank you.